Aditi.
At the outset, I'd like to thank AIS for this opportunity. So it's a very basic talk to look at some of the most common things one sees in the OPD. So it's not just for the retina people, because we day in and day out see OCTs. It's also for anterior segment surgeons, because
Dr.
some of
Ritin
these
Nanda is not there? Okay.
can help you prognosticate better. So OCT was first done in 91, and over the years it has evolved, of course, to ST-OCT, SS-OCT, and now Octa. So I'm skipping that part. Oh, to interpret an OCT, one must know what a normal OCT looks like, and it looks like this. And we have a nomenclature that gives us these 18 points of all the layers that are on the OCT. And one must know this to be able to interpret at which layer what disease is existing. And it's always better to understand and read every OCT layer-wise so that one does not miss things. So I'll go similarly and also with a mix of few common conditions that are seen. Typically in the vitreous, you may see some, early bleeds. This is obviously a frank bleed. There is a subhyaloid hemorrhage which can be seen right there. But sometimes even posterior vitreous cells, which are very subtle, or a very, very mild bleed can be seen on an OCT at the vitreous interface. Moving on to vitreomacular disease interface disorders, there is the big bright yellow arrow that shows a very fine ERM, and clinically you may be able to pick it with the particular sheen. The other OCT is, of course, of again ERM with distorted retinal layers. So that's an epiretinal membrane. Again, in vitreomacular traction disorders, we have vitreomacular adhesion on top, and also vitreomacular traction, where it also pulls the retinal layers, which can either be focal or broad. And that's based on whether it is less than 1500 micron or more than 500 micron. We also have macular hole and various stages of it, right from the traction to an impending hole with partly the operculum attached to a full thickness macular hole. Very commonly seen in our OPD. We also have a pseudo hole wherein you can see that the ERM is causing a tangential traction and there is a verticalization of fovea. So that's a pseudo hole. And then you may have lamellar hole, where typically you may have split in the retinal layers. There can be loss of tissue as well. Very commonly seen as diabetic macular edema. It becomes important to understand which is center involving. Some of the ones shown here are center involving. Non-center involving are typically not treated with an anti-VEGF, and central involving is treated with an anti-VEGF. Here you have different types of it, though we most commonly encounter a mixed variety of all this. We have spongiform, cystoid, you can see the cystoid spaces, serous, and tractional edema. And we may also see a taut posterior hyaloid in some of these diabetic retinopathy. Here I would like to stress on the biomarkers beyond the scope of this talk, but it becomes important because this can affect vision. DRIL is disorganization of inner retinal layers. You can see on one side, you can make out the retinal layers very clearly, whereas on this side, you cannot really make that out very clearly. So that is indicative of ischemia and also poorer outcomes. Others being hyperreflective foci, which differs from our hard exudates as they are smaller, they don't have backshadowing, and it shows chronic inflammation and long-term edema. And another important factor is to always look at the outer retinal layers. If their integrity is not maintained, your visual outcomes long-term are not going to be great. Moving on quickly, the first OCT may look normal at the first glance, but you can see a slight hyperreflectivity right there. That is early stages of a PFT or a MACTEL, macular telangiectasia, and that of course is the ILM drape sign, typically said to be a degeneration of Mueller cells. So sometimes clinically it becomes difficult to pick up these, especially in today's era where you are planning premium lenses. Clinically are not able to pick this up, sometimes may have visual impact later. Moving on, any guesses? One of the most common things again you may see. A subtle clue here.
Arterial.
Yes, that's arterial occlusion, and that's how an acute one looks with inner retinal hyperreflectivity and a darkened outer retina. And sometimes you may get a patient who's once had an arterial occlusion comes back with a complete thinning of inner retinal layers. That's how it looks on a chronic stage. Similar thing if it happens to one branch, that's a BRVO. Same thing, any occlusion. Sorry, BRAO, I'm sorry about that. BRAO, you have the same thing, ischemia, therefore whitening of the inner layers, darkening of the outer retina, and you see a normal retina on the other side. Look very carefully, you can see two white patches there. These patients may come to you saying, of a central or paracentral scotoma. And this is a very subtle thing. It's a middle layer ischemia that leads to something called PAM, parafoveal acute middle maculopathy. Clinically, they may look normal, but you can pick this up on an OCT, and you can obviously tell the patient that there has been an ischemic itself. So these are the things that we saw occlusion at various levels. Cottonville spot is, of course, occlusion or a nerve fiber layer infarct. So I've just put it there. Moving on, vein occlusions. Vein occlusion here shows a massive edema, and clinically, of course, you see substantial level of hemorrhages all around. Same thing when it happens in a branch. You have a branch retinal vein occlusion, and you see edema involving only that section where you can see cystoid spaces, a small sensory detachment right there. Moving on, another common disease is age-related macular degeneration. The dry variant typically has drusen or geographic atrophy. In drusen, at the layer of RPE, you can see these tiny bumps. They are, and in geographic atrophy, you can see the entire central subfoveal area where the outer retina and the RPE, the entire thing is atrophied. Neovascular AMD, of course, can be another topic of discussion. There are various types of it, but typically you see a membrane. Here you see one above the RP with a lot of intraretinal fluid, clearly requiring treatment with an anti-VEGF. Another common thing that you can come across is young patients coming with this detachment, and people not able to sometimes differentiate what it is, but it's very common to have CSCR, and it is self-resolving. Typically you see a PED with a serous detachment right there. This is also commonly seen these days. You have something like a notched PED, you can see a notch there, or a thumb-like PED with subretinal fluid, and a double layer sign. You can see a Brooks layer separately and the RP lifting up with some fluid above it. Typically, PCV, of course, there's a lot of variants of the entire pachychoroid spectrum. Here, look very carefully, it looks normal, but you can see a slight split there, right above the RPE, that denotes a photic retinopathy. So sometimes it's important. Some people may have blurred vision because of this. Another common thing is ocular trauma. Of course, it has a very frank, ghastly picture sometimes with bleed and choroidal rupture. And this helps us show the patient also why the vision is less. And subsequently, with these ruptures, you may have CNVMs later and all of that. So helps in documentation, educating the patient, and also warning them of what can go wrong in the future. Look at this very carefully. You can see that bright RP band, and above that you can see a small layer of photoreceptors. Now that has to continue on either side, but it stops right there on either side. So this is a case of retinitis pigmentosa where there is a parafoveal loss of photoreceptor layers. So sometimes what happens, I've seen a lot of cataract patients, clinically you may not be able to see those bunny spicules or attenuated arterioles, but scan can show you this, and you can certainly explain things to the patient, prognosticate better, and guide better.
Aaditi, can you please wrap it up?
Yes. So to summarize, the OCT is an important, extremely important tool for all subspecialties, I feel, because it's a simple tool, and it's very graphic, and it shows you all the diseases very clearly in the layers. Thank you.
Thank you, Aditi. It's a very tough task, 7 minutes, an entire OCT book, virtually you have summarized, but I think you gave a lot of very, very good examples. But you see, to suffice, I would like to say, whenever you are interpreting OCT, don't behave like super consultants and say edema plus and give injection. That's what, where most of us falter. So you should have those 4 lines always written up. like, you know, a lot of people interpret X-ray and correlate clinically. So we see a lot of such nonsensical, stupid statements. But like you rightly started, start from vitreous, interface, inner retina, outer retina.
Yes.
Then you will never falter what you are dealing with. So message is that don't write edema plus an injection. That is what is becoming, spoiling everybody in fact. So if you follow what you have said,
Yes.
start from vitreous, interface, inner retina, outer retina, you will always benefit. No?
Yes,
Aditi?
certainly.
Chal, I think with this, we have a lot of things to be discussed, but because of shortage of time,
I am
think-
around.
yeah.